up or thumbs down, but let me go ahead and introduce myself. I am Dr. Amol Bhalla. I am the Senior Director of Clinical Informatics here at Intelligent Medical Objects. Just a little bit background of myself. I've been in the healthcare and healthcare IT industry for almost coming up on 2 decades. So it's really, this area is like my passion. I love it. Uh, I can talk to the moon about it. So what I like to do is today is kind of like give a little bit of a background on the journey of clinical informatics or informatics in general. Then kind of go into a little bit of details around interoperability, the 4 pillars, and then how LLMs can really play a role and, some of the gotchas with LLMs too, and how we can see moving the industry forward with this disruptive technology. So let's just jump into it. So the journey of clinical informatics, the evolution of clinical data. So I like to say before the 1960s was the dark ages of clinical informatics. Everything was documented on paper. Some folks on the call may remember going into their primary care office and looking at the back walls, and there's just a plethora of like those manila envelopes that are indexed correctly and just hanging out there. So around the 1960s, a bunch of academic institutions were developing the precursor to the EHRs, and they were called clinical information systems. So the big players back in the day were Lockheed Martin. They developed, an influential system that eventually became a part of Allscripts, and it's notable for speeding up the processing capabilities, and it had supported multiple users. Then around like the mid 1960s, the University of Utah and 3M collaborated to create HELP, which was one of the very first clinical decision support systems. Fast forward a little bit to 1968, and this is where kind of like the more modern EHRs were coming into play, which was the CoStar system, which was built out at Mass Gen in conjunction with Harvard. Some of the really cool key features about that clinical information system was it was a modular design. So it's behaving more like the current EHRs today, but also behind the scenes, it had a flexible vocabulary, which recognized various terms for single diseases, which was completely novel. In the 1970s, you could start seeing where the federal government was going into the EHR space, and they created Vista, which was utilized at the VA side. And this system was actually called the Computerized Patient Records System. And it's still widely used today by medical professionals. Let's go ahead forward to the 1980s, and this is where you start seeing commercialization of like EHRs. One of the really fun things is along that journey with the more modern EHRs is groups like HL7 was establishing. Go towards the modern EHRs in the 90s and beyond, you can see where we are today. But also some fun facts is in the mid 1990s, IMO established itself. And then some fun interoperability platforms like Cloverleaf were coming into play. And then in 2009, that's when we started really just having fun with like high tech and everything in between. So, but what you want to kind of take away from this is that the journey has been to migrate from a written note to a digital medium. And you may be asking, why are we doing this? Why are we doing this? Well, it's really hard to leverage clinical notes when they're handwritten. It's hard to find them. So going towards this type of paradigm of digitizing them made them really, really enabled. So let's go ahead and that's when you could see like the digitization and all the players now in the industry and all these solutions that we can look at. But what was also going behind the scenes was that health systems themselves were being bought, sold, traded, merged, and they were evolving this from CISs, the clinical information systems, into EHRs. Also, clinical data itself was evolving. The clinical content was evolving. Processes, workflows, revenue practices, and the list goes on. So this evolution has been going on since the 1960s. And, it kept us informaticians super busy. We had to, abide by regulatory rules, compliances, data governance practices. So we were literally building the plane while flying it too. Jordan, I think we have some questions we want to ask the crowd. So I want to take a breather.
Yeah, let me go ahead and launch them. Hold on 1 second. All right, so in what areas are your organizations investing in when it comes to AI technology? Is it in deep learning, machine learning, natural language processing, LLMs, or you don't really know? I'm gonna give it a few seconds while everyone answers. All right, we're gonna go ahead and close out. So it kind of looks like NLP is where people are headed, Amol.
That's great. That's really awesome.
And then we're going to do an additional one. All right, what types of barriers are you hitting? Is it financial, resources, content and terminology, or technology and infrastructure? A few more seconds. Okay, thank you. All right, so it looks like technology and infrastructure and content and terminology and resources are all kind of close there.
Oh yeah. The folks that love to learn more about the technology and infrastructure challenges, folks can chime in at the end of this talk and ask some questions. That'd be great. All right, so let's continue on. So when I referred to content evolution, I'll be very honest, in PowerPoint, it's really hard to find like handwritten text. So if you see that little squiggly stuff says mail, I'm trying to simulate text, handwritten text, I should say. What was happening is that we were evolving from handwritten notes, but then we were also involving these computer information systems to EHRs. There really wasn't any structural, like referential terminology out there that supported this behind the scenes. So folks were using localized codes. You'll hear that sometimes. A localized code is literally like somebody like me sitting at the health system saying, hey, this is what we need to do. And that would be like, okay, let's use mail as an example. We'll just use capital M as mail. Coding systems didn't really start coming into play until about the mid 80s, but there was a lot of localization efforts going on behind the scenes. Other areas where folks were doing was just doing just a string descriptor, like, hey, this is typed out mail. Longitudinally, as these health systems kind of like merged together, were bought and sold, so was this data. So you had a time where there was clinical handwritten notes, there was these localized codes, there were some coding systems being utilized, and then there was just everything in between. And at the end of the journey, everybody kind of had this hodgepodge mess. And then as we evolve the clinical medicine practice, we also see new domains coming into play. And that's like the genomic information that's really coming into play today in our field. So when you look at the data, you kind of have like what we call low fidelity data or low precision data to high fidelity data. And so once again, you had something that describes something, the phenotype of the person as like handwritten mail or a full string description of mail. Then you had something like codable concepts, which is your capital M, your 0, 1, which is actually if I remember correctly, is the reference for HL7 mail. And then you have the SNOMED code right there, which is 248153007. And now as we expand to the genomics domain, what you call, we are seeing that it's you're genetically XY. So that's your super high precise data. But there's an issue. And remember, we're trying to make sure that people understand that, we are talking about male. With low fidelity data, it could mean a male gorilla, a male peacock, a bull, a male lizard. But when you start getting more precise, like XY, that is a genotypic human male. So as the domain evolves, the content evolves, and also the language to describe that content evolves. So what does this all mean in semantic interoperability? All right. So clinical interoperability refers to the ability of different information systems, applications, and software to communicate, exchange, and make use of patient and other clinical information in a coordinated way. That's just a fun way, as informaticians like to say, is we're trying to transport data from A to B and ensure that the original clinical intent remains intact. So if I was going to send something to another physician, I want to make sure that the physician on the other side understands what I'm trying to say. Now, there's various dimensions of interoperability: foundational or technical interoperability, syntactic or structural interoperability, semantic interoperability, and organizational interoperability. We'll dive a little bit more into the syntactic and the semantic interoperability in the subsequent slides, but foundational interoperability, really at a basic level, is when a health information system can really send and receive information from A to B. It's very rudimentary, so I want everybody to, this is going to date me, and maybe some folks on the webinar too, is think of fax machines. Yes, healthcare today still uses fax machines, but really it's just, hey, I'm going to send this person's clinical documents over the fence. Organizational interoperability is one of the newer forms of interoperability, but that is what you want to think of as like the data governance aspects of clinical of the domain. So let's jump into the syntactic. So syntactic or structural interoperability really ensures that the data exchange between information systems are preserved and unaltered. We kind of look towards like schemas or mechanisms of transporting data. The big standard out there is HL7. They have V2, which is very popular, and also FHIR. But this allows us to kind of structure the information and kind of form fit it so that the party that's transmitting in hospital A, the hospital B system knows what they're going to receive, and they can validate what they receive. So it's literally the format and the structure. You can also think of it as the data model or schema, and it's really a standardized way of transforming and packaging a message. The other aspect is the semantics. Oops, looks like we got a little bit of a slip up. So the semantics is kind of plays the influence of what goes into that schema. So in this, how do we go back and correctly codify this information? How do we kind of get all the handwritten mails, the unstructured string mails, mail as an HL7 code, the localized code of 01, and the SNOMED code to semantically align to define it as mail? And that's where this is going. So we've seen the content evolution. Now we have to basically align that content into something meaningful, package it up, and transport it across the fence to our next health system. That's where semantic interoperability and syntactic interoperability kind of play this synergistic role with one another. But the one takeaway you want to think about semantic interoperability is that it really ensures that the sending and receiving systems understand the data similarity. It's about really establishing a common language for precise and reliable machine-to-machine communication. And so that means that we are really trying to make sure that when I, Amol, send data over to one of my colleagues in another health system, they know that I'm referencing a male patient. So Jordan, I think we had another question. So let's go ahead and ask the crowd. So Mike, I had a question saying basically how many coding systems are there? So
Yes, how many coding systems are there? Hey Amol, I don't the poll question didn't go through. So you can
did
continue.
it? Okay,
Yeah.
cool. No worries. No worries at all. Okay. So now we've talked about clinical informatics or informatics, the journey from a clinical information systems to the modern EHR. We've talked about how we can package up that information. How do we ensure codification of that information and making sure that the clinical intent is intact as we transmit data from A to B. Also, a fun reminder is that clinical medicine is also its own language. Here's a fun little thing is like, when somebody says, hey, I hurt my hand here, or I hurt my hand here. If you talk to a clinician, they're going to say, hey, did you hurt your forearm on the distal side or the proximal side? And so we have our own set of linguistics, our own vernacular, but even there's some colloquialisms. And then on top of that, what we encounter too is that the influences of the physician's training, where they're trained, how they're trained, and what areas they're trained in also influence this language too. So that's where we're going to go with how does LLMs play into this? Now, I want to do a shameful call out to a fellow colleague, Dr. Xiaoyan Wang, for this slide. If you guys haven't met her, she's amazing, but I want to thank her for this one. So LLMs are an intersection of various machine learning approaches, making them really a super fascinating area to work with. If you look at the slide, they're a combination of various machine learning approaches, and they are at the center of it. But I like to just take a moment and kind of talk about like the backgrounds of where LLMs have evolved and where we kind of see them going into. But the initial models, like the initial LLMs that were coming out, were really just rudimentary. They were n-gram models. They were simple. They were based on word frequencies. They really didn't have what we call today's like the self-attenuation. They did not capture long-term dependencies in the language. After that kind of came the neural networks, and neural networks are really what you want to think is the deep learning aspect of an LLM. So the ones that were really leveraged in the past are like the recurrent neural networks, and then a very specialized form of that, which is long short-term memory. And that really became popular longitudinally. That kind of gave us the foundation to the next evolution of LLMs, which is the transformer model and the attenuation mechanisms. So Google, they've been on the forefront of this area. So the researchers at the Google Institute, I should like to say, introduced the transformer architecture, which really made use of the attention mechanisms. And this allowed the model to weigh the importances of different words when producing an output. And then this very foundation, the self-attenuation, became the current architecture for subsequent LLMs. And then in 2018, Google dropped another really fun piece of technology, which was called BERT. And BERT stands for bidirectional encoder representation from transformers. So BERT is kind of it's a fun piece of technology, but it really did set a new standard for multiple NLP tasks, proving that the power of unsupervised pre-training was really possible. Then, kind of like the evolution, what you call the evolution of OpenAI. So OpenAI introduced their first GTP model in 2018. And it was really just a small precursor to what it is today. So GTP-1 used 10 million parameters as inputs into training it. You fast forward to 2023, which is to the dawn of GTP-4, it has gone to 1.76 trillion parameters to train that model. And why? They're trying to replicate natural language. They're trying to go to that level of processing, making computer processing, that type of linguistics. And then on top of that, that's where you're seeing the dawn of like the imaging analysis too come out from OpenAI. And last night, I love looking up fun facts. If you get to know me personally, I'm always full of really random fun facts, but it was finally released how much OpenAI paid to train GTP-4. And it was roughly calculated in operational costs, not hardware costs, but operational costs in training and everything in between the resources across the board was somewhere around $63 million. But the hardware itself is super expensive too. One of my colleagues over here did a really fun deep dive into this domain too, and found out that one of the GPUs that they use for this type of training can cost upwards to $70,000. So it's very, very expensive to create your own LLM. Some other, notable LLM models is the T5, which is the text-to-text transfer transformer. This was also done by Google. And then Roberta, which was by Facebook. It was based on a version of BERT. And there's so many fun little BERT examples out there. But you can see that LLMs in themselves are a combination of various machine learning activities, and they're evolving really quickly. So Jordan, I think is the poll up and running?
Yeah, we can go ahead and launch that one.
Let's go ahead and ask.
All right, so how many known coding systems are there? Kind of a pop quiz. So are there 5, 25, 50, or just too many to count? Give it a few more seconds and then we'll share the results. All right, I think majority is saying that there's too many to count.
That is absolutely the correct answer, folks. It is too many to count. Why are coding systems so important to us? Remember, it's making sure that the semantics of the data remain intact. As I mentioned, there are a plethora of coding systems out there. SNOMED CT, ICD, CPT, LOINC. Oh my gosh, there's RX Norm, HICPICS, NDC codes that are part of that too. ICF, ATC classification, CMT. There's also MEDRA, and then you also think about this is that if you take a kind of lift under the hoods in certain international domains too. I remember South Korea had KCD, which was the Korean classification of diseases. They had HIRA. If you went over to Japan, they used ICD-10, but they also had their own Japanese drug dictionary. But what you got to take home is that medicine is its own language, and there's localizations of that language, their own colloquial expressions of these languages, and we look at structured terminologies like a SNOMED or an ICD to help us align our colloquialisms, our colloquial expressions, to something that is a known term. So let's go ahead and continue on. So to kind of show you a little bit about where we can use LLMs to support semantic interoperability, we did a little mini experiment here. So this is a very, very, very high level example. Please do not, it was just something fun to play with and just to show an example of. But the way that I look at LLMs, or my current perception of LLMs, is I look at it as a mechanism to really kind of use our natural language to do something in a question answer manner. So that may be interacting with data, but in our example here, I wanted to look at a natural clinical, like a clinical note written by one physician, and then the same patient seen by another physician who are maybe, let's say hypothetically, are looking at the same person who came into the department with right upper quadrant pain. So hospitalist A writes down a 32-year-old male patient presented to the department complaining of upper right abdominal pain. And then a 32-year-old male patient presented to the ED today with primary complaint of abdominal pain located in the upper right quadrant. So what you want to kind of think about is the general challenges that we see in medicine. These are, I'm just going to harp on it again, these are really rudimentary, notes, but we have two of the hospitalists, they're seeing the same patient, they write their narratives, but what we need to do is to make sure that the semantics are intact when we start analysis upon this report, right? And we can look towards an LLM to do that. So let me go ahead. All right. So I took both examples from the hospitalists as inputs into my LLM, and I asked my LLM, can you extract the relevant medical codes from the following text? Now, remember what I'm trying to do. I'm trying to elucidate the semantics of the clinical text and figure out which codes I should use. So let's go ahead and go on. We know that the two clinical notes pertain to the same patient, but our LLM does not. Combining both clinical notes may provide the most insights. So if we merge them together to define a clinical encounter, but an LLM doesn't know how to do that out of the box. So how do we account for that? So it's a running question is, how do we merge everybody's documentation together to derive a rich clinical insight or a clinical narrative and codify that? So in this example, what you can see is the LLM extracted the medical diagnosis of right upper quadrant pain, and then it provided the ICD-10 CM code, or actually this one provided the ICD-10 code. But the issue is how do we know that's the right code? How do we validate that? But also, did you notice that male, which we codified in our previous example, is also missing from this too? And I always love how LLMs behave sometimes, is that I really enjoyed the response. And the second example was exact coding might require more specific clinical information and potentially the use of dedicated medical coding tools. So that's they have their own personality too, it seems like. So then what I did was I grabbed the second hospitalist's information, and I said, can you extract the relevant medical codes from the following text? Can you use ICD-10 CM and SNOMED CT as the two medical coding systems. And I ran it again. But how do we validate these are the correct codes? How do we validate that it's the correct SNOMED code? And then once again, male was missed. Then let's say I want to run this example over and over again, right? How do we repeat the same experiment over again? How do we continuously extract all the relevant clinical concepts and then utilize those clinical concepts in an interoperable manner? So what I'm trying to harp on, folks, is that an out-of-the-box LLM solution may not fit your domain's needs. And there's also a lot of other gotchas going behind the scenes, and we'll go into that. So LLMs like GPT-4, Bard, Llama 2, they've shown a lot of really impressive capabilities of looking at natural language and linguistics, but they come with certain challenges and issues too. They're really susceptible to biases because LLMs are trained on vast amounts of different disparate data, and they can actually inherit and amplify the biases presented on the training data. And this can lead to some really interesting outputs that may reflect societal biases related to race, gender, religion, and more. They can also be very overgeneralized. LLMs can make, really general statements sometimes. One of the big issues that we also see in clinical medicine is we use a term called data provenance, where LLMs have the lack of explainability. It's really hard to decipher where and how an LLM generates an answer. They're super susceptible to inputs. In the examples I provided, I did not train the LLM with any sort of prompt engineering. I just asked them raw questions, and then subsequent questions, I just created a new session and I threw it against it again. But they really are susceptible to inputs. They're also really difficult in handling novel concepts. If the LLM hasn't been trained on recent events or the latest knowledge, let's say a brand new breakthrough in a drug came out, the LLM won't be aware of it until it's retrained again on that area. And the example is they're very expensive to train too. There's other things like overfitting. There's also concerns around, economic and environmental factors. These are using a lot of computer power, generating massive amounts of CO2 emissions. And then another aspect is the ethical usage of them, which is like the safety and the misuse issues. One of the funniest thing is that what we saw in this presentation was sometimes they lack just common sense. So LLMs can, they can generate sound and plausible results, but sometimes you have to take a moment to validate those results. And I think the current term is hallucinations is we're going to. But I apologize. What if we decide to, give it a source of truth, right? Support it, augment the LLM, support it from the side, giving it the domain specific language, giving the colloquialisms, training it on what does distal mean, what does proximal mean. And that's where we can see the future of LLMs allowing us to support our clinical activities, codifying a natural a text file or some sort of free form document or an image. We can give it that. Then we can use that in the outcome of that in an interoperable manner. But also LLMs, we could foresee disrupting other areas like clinical decision support, patient cohorting, clinical trials enablement, and the list goes on and on. So we do see this as very much a disruptor technology in the industry, but it needs a sense of what clinical medicine is. So a couple key takeaways I want everybody to take home from this webinar is an out-of-the-box solution will require some investment if you want to utilize it in a healthcare setting. LLMs can really enable that semantic interoperability, but they require that training and augmentation. So they have to be really trained in that area. And, I'm going to leave this bombshell is stay tuned because IMO has something up their sleeves. But if you're interested in getting started in LLMs, there's a couple key sites you can look up, Hugging Faces, Towards Data Science, or you can reach out to us directly. So with that, I'm going to open up the floor to some Q&A.
Thanks, Amol. So we have a few questions that came in already.
Cool.
What do you think the cost associated with training an LLM is?
So the cost associated with training an LLM goes down to a combination of access to data to train it upon, the cost of compute. Remember, I was saying is that one of these GPUs costs roughly, can go up towards about $70,000. If I remember correctly, and somebody can fact check me, Llama 2 utilized, I think it was 2,000 of these GPUs. So you could do the math of just, let's say, 70K times 2,000. And, right there, that's the cost of the hardware. Also, you got to think about the operations behind the scenes. And you look at that, and it's just the combination of hardware, just general electricity, the subject matter expertise, the sources of data. It's a staggering number. So that's where I spent some time last night just trying to find those numbers, and GTP4 was $68 million to train, and said and done. Cool.
Nice.
So let's see. Is IMO close to publishing an NLP LLM tool? So we do have a NLP solution. It's under our Melax team. You can reach out to us. We can talk about precision normalized. We could talk about precision NLP, yeah, just feel free to reach out to us about that. RAGs can help LLMs deal. Another question: RAGs can help LLMs deal with needed context, helping alleviate the issue of hallucination. However, there still will be issues around explainability of LLM results as sensitivity to inputs. Any comments on how IMO is thinking about these concerns? Right now, I'll have to answer that question offline, to be honest, because we do have a couple things up our sleeves as we are investing heavily into this area. So I'll answer that one offline. And then another question came in was, how do you propose structuring more semantically complex concepts that don't fit into existing vocabularies? So IMO has been doing that for 25 years now, is helping support behind the scenes using our interface technology to semantically align how a clinician speaks to a known code system. So if we leverage that capability that we've been building for 25 years, that's how we would approach that. All right. So if you have any more questions, please chime in. We got some time.
I know this was kind of mentioned before, but another question was, do you see IMO fitting into this space?
Oh, definitely. As I keep on harping about, is we've built a language for over the last 25 years. We've done everything and anything to build out that type of language. And so we do see ourselves fitting into the space quite naturally.
All right, so I think we can go ahead and close out. We hope you found the information in today's webinar useful. Awesome job, Amol. If you have any questions, you can contact our sales team at sales@imlhealth.com. Thank you so much for attending, and I hope that you have a great rest of your day.
Alrighty. Thank you, everyone.